Okay, so thank you for your kind comments. Dr. Iakovou, thank you so very much for inviting me to this outstanding meeting. As Dr. Vavuranakis said, he's doing lots of paravalvular leaks, so I suppose some of the images are going to be familiar to him, especially if his hospital radiologists are doing the appropriate imaging with the appropriate CT scanner. I have nothing to disclose. And prosthetic heart valves are devices that were first implanted in the United States in 1952 by Charles Hifnagel. And as everything that is inserted in the human body has a tendency to be rejected, the human body has two nice attributes. One is it doesn't like putting mechanical or foreign bodies inside, and second, whenever there's a hole in the body, it tends to close it with fibrous tissue. So consequently, when you put a heart valve in, complications may arise, and some of them are dysfunction, dehiscence, endocarditis, thrombosis, pannus formation, pseudoaneurysm, abscesses, and PVL, which is the topic of my presentation. What is a paravalvular leak? It is abnormal flow through a channel between the valvular prosthesis and the native valve annulus due to inadequate sealing. In other words, it's something that shouldn't be there. It is characterized by inappropriate apposition of the prosthesis ring to the native tissues, and this leads to perivalvular regurgitation, and unfortunately, it's a relatively common complication of both mechanical and bioprosthetic valves, slightly with a greater preponderance in the aortic valves compared to the, in the mitral valves compared to the aortic valves. The most important statement in this slide is that the most common cause of PVL is endocarditis-induced dehiscence. And interestingly, PVL can be seen in the absence of definite signs of dehiscence owing to alteration of the normal geometry between the valve and annulus, and that's induced by anatomical and hemodynamical changes of surgery. PVLs are common, 5 to 20% immediately after implantation, especially in the mitral position. And most patients with a small PVL go asymptomatic or even undetected initially until mild hemolytic anemia may kick in. However, large PVLs are seen in less than 1% of surgeries, and those can result in heart failure, severe hemolytic anemia, or endocarditis. And this is schematically how a paravalvular leak looks like. We have two chambers, two lumina. North, we have the aorta, and south, we have the left ventricle. You see the implanted aortic valve, and next to it, you see an S-shaped ribbon, which is the leak. And you have a very nice coronal reformation of, in a CT scan, where next to the aortic valve, which is dehiscent, you see a connection between the aorta and the left ventricle. Now, how do we diagnose PVLs? To begin with, maybe far and foremost of importance is the clinical history and clinical findings. That's hemolytic anemia, heart failure, and endocarditis. The first imaging tool is echocardiography, and transesophageal echo is the gold standard. And when it comes to CT, you have to see a contrast-filled channel in the paravalvular region that connects the two luminal. Now, as you will see further down, you have to have a clinical suspicion. So please, when you're suspecting a PVL, let us know that there's a questionable PVL in the CT scan that you're about to perform and read, because maybe the most interesting part of PVLs and CTs, no matter how good they are performed, is that they are very, very easily missed. Of course, you can do MRI, but MRI has a lower sensitivity, mainly due to the artifact, and MRI cannot image in a volume like CT does, so the performance of reconstructions in double oblique planes is rather limited. But if you do it, and if you see it, then it's there. Now, as I mentioned earlier, 3D transesophageal echo is considered the gold standard of reference for evaluating PVL. And again, what you're looking for is a contrast-filled channel in the paravalvular region. Now, this is a rather extensive technique of how it is done. Again, the most important part in the technique is clinical history. You have to do, of course, a gated scan, and all the other parameters that you see here are just, details that we can take care of, radiologists, I mean. So here are some examples. Up and to the right, you see, we see a jet as seen by ultrasound. On the left-hand side, we see the channel. Do we have a laser pointer by any chance? Lovely. Okay. So this, okay. Over here is the channel. That's the PVL. And over here, it's a much smaller channel. That again is the PVL, but this is very, very easy to miss. Even if, as you can see, it's a targeted image, the radiologist who did this examination knew where he was going, knew where to look. Despite that, it is very, very easy to miss this little channel. Again, here we have an image of a PVL in a mitral valve before and after therapeutic intervention. This is one of our cases. This is the left atrium. This here is the left ventricle. This here is the valve, and here is the channel that connects the two lumina. This is the channel. This is the PVL. Okay? That same patient in views that took some time to perform and construct. You see this crescent-shaped white area? This is the PVL. This is the PVL. And this here is the prosthetic valve. This here shouldn't be there. Again, we can perform measurements in double oblique images. Same here, same here. And when you report those PVLs, you have to follow a standard. In radiology, when we read images, we read them as if we're viewing the patient from the feet, from down up. When you are reading images in transesophageal echo, you read them from what I have read the other way around, as if you're viewing the patient from head to feet. So the images are flipped. So this is the image that was, sorry. So this here is the image that is flipped, and this is the initial image. With artificial intelligence and reconstructions, we can also perform casts, three-dimensional casts before and after interventions. Here is another PVL, okay, right here. That PVL was closed, was sealed with coils, and here's a cast of the coils after intervention. This is what I meant earlier when I said that it's very, very easy to miss. This is a case that was done a couple of months ago at our institution. Personally, I read it as normal. And then Dr. Athanasopoulos came to my office and said, I remember a case I told you a couple of months ago, so yada, yada, yada. With Dr. Iakovou, we had just finished reviewing it, and you know, then everything started falling in place. And as Dr. Athanasopoulos was telling me what happened, my hand was performing the three-dimensional reconstructions, and when I reached this image here, he said, yes, there it is. So this here is the prosthetic valve, and this here, between 1st and 4th o'clock, is the PVL. And in order to conclude, the most important thing is history and clinical suspicion. Think about it. Have a high index of suspicion. Know what you are looking for. It is very, very easy to read an abnormal CT as normal. The first imaging examination is echocardiography with transesophageal echo, the gold standard. And in CT, what you need, the sine qua non, is a contrast material filled channel in the paravalvular region that connects the chambers proximal and distal to the valve. And again, it is very easy to miss. Thank you for your attention.
Thank you very much for a very precise and excellent presentation. Just a couple of questions, since you know that is actually common in the practice. From our experience, we have also Tao, who is very experienced also too. I mean, for mitral, we rely mostly on the transesophageal echo during the procedure to see what we're going to do. But for the aortic, it's very useful if you have given us some indication by CT what angulation could be precisely, you know, imaging the exact position of the leak. And my question is, a lot of the times, all the angulations that you as a CT analyzers provide, and operators provide me, do not reflect what I am seeing in the cath lab. And the question is it position of the patient? Is it because sometimes it's hard to see exactly where the leak is? And why is this discrepancy? I don't know if you notice that discrepancy is also, Gianni, in your institution, but this is something that I do. And this is the reality. And the question comes also because talking to different meetings, you know, is that, well, we don't have the SPECT CT, which theoretically would image some flow. So it's nice to see your opinion, why this is happening.
Do we have PVLs?
Well, we have, but we have a multidisciplinary team in our center.
I've noticed that.
And we always consult Dr. Vrachliotis in the heart team and Dr. Nyktari from time to time when we deal with the complex situation. But of course, we have the echocardiographers as Dr. Tsiapras, Dr. Athanasopoulos. For instance, in this case that you just very nicely showed. So we were dealing with two failed rings. One heart ring in the aortic valve that we did TAVI, and another ring, failed ring in the mitral position, a semiform ring, 32, so with paravalvular leak, which was not evident in the 3D printing that was based on the CT, but we had to rely in the TOE images that we show clearly that it's a paravalvular leak, you know, on top of the central leak that it's due to the rupture of the neocordi. So we were planning to do a paravalvular leak closure based on the TOE findings. Yeah, so this is really interesting.
John, my question is whether the angulation that they are giving you, because you are giving angulation, is that right? The appropriate angulation to approach aortic paravalvular leak, for example. You do give them.
Of course.
Yes. Do they correspond what, I mean, in what you're actually getting in the cath lab?
You have to make them correspond.
Well,
you
make
know
them.
what you're looking for, and it's something that you must be doing quite frequently. So there needs to be some experience. You mean to go in appropriate double oblique images in the aorta, you know, image that much sagittal, that much coronal, that much?
Yes.
Yeah. Well,
I mean, that's what I'm asking, the corresponding.
Yes, so maybe we would discuss with the echocardiographers about,
Because this is different. The echo shows it clearly. I don't know, Theo, what is your experience? You get it, appropriate orientation? Because
I fully agree that for the mitral paravalvular leaks, real-time 3D transesophageal echo is very, very important compared to CT. For the mitral leaks, we never use CT, but for the aortic leaks, transesophageal echocardiography also give nothing, really. If there is a large leak, T shows suspicion about paravalvular leak. And for me, many people also think that aortic paravalvular leak closure is an easy procedure, but some of the course of the leak, like the S-shaped, double S-shaped leaks, it is very hard to put the device. You can cross the leak, but our selection of the device and the results are sometimes not satisfactory. In that kind of leaks, CT can be really useful. That for me, CT is very useful for the aortic paravalvular leaks, especially course of the leak. If it is, for example, double S-shaped type 1, type 2, and the terminology also is different, and I will give some examples in my presentation in aortic paravalvular leaks, where the leak is, for example, the clog formation is different in some publications and in another publications.
And I think the example you showed
So CT is very important in that kind of situations.
The example that you show clearly show a leak that was coming down and then became horizontal, and that's very difficult when you try to position the device that will not actually, sometimes you will not close the leak and you have this perpendicularity. We have Dr. Nyktari next to us. I don't know if, yes.
Complete, I think, the answer you.
So, I don't know if you hear me.
Okay.
Dr. Nyktari should make a comment, I think, or not?
So, first of all, congratulations to all the presenters for the high-quality presentations they made. I think going back to your question is that probably echocardiographers who are working very close with interventional cardiologists who put prosthetic valves, transcatheter, are more familiarized to what you need. Because I find it difficult that a tomographic modality like CT or even MRI cannot accurately give the angulation and the course of the leak. It depends on the reconstruction you want, and probably this is a communication failure between us and you. And as it applies for everything in life, the best modality is the modality that is more accessible to you and you have been more familiarized to. To make a comment on the value of cardiac MRI, because I'm performing cardiac MRI the last 10 years, I have to say that it is an option in frail patients whenever you want to avoid radiation or contrast. And it can give you by using a 3D data set from a single sequence, it can give you all the data to reconstruct at any available angulation or plane. And I think most recently there was an interest on how to quantify the paravalvular leaks, and it seems that the echo underestimates in some cases, difficult cases. So CMR is promising on quantification. And especially in the aortic valve position, it can also give you anatomical data because you can image the entire area and then take the plane where there is no artifact and quantify and visualize the leak. So we are a very good optional choice, and expensive and not that accessible, but we can do it. But going back to your question is probably a communication fail between the two teams, the imaging team and your team.
Okay, well, thank you very much. I think we're going to proceed for the next case. It's a great pleasure. May my co-chairman will introduce you.
To introduce